Yeah, you are on live. Thank you.
Good evening, dear all Facebook Pure Urology viewers. So today we have our special speaker, expert professor, Dr. Manoharan Murugesan sir. He is going to talk on the tips and tricks of neobladder in women, the robotic technology with intracorporeal neobladder. So this neobladder is not a commonly performed surgery, and there are multiple options. There are quite a lot of varieties of techniques which have been described in literature and have been practicing worldwide. So right from the Studer's neobladder, right from Kemi's description, we've got a lot of modifications, picture pot neobladder and so on. So coming to the technical nuances, what is the right option and who is the right patient? We would love to hear from Dr. Manoharan Murugesan sir, who has been kind enough to accept our invitation. So let me take the privilege of introducing sir. So the topic today is robotic intracorporeal neobladder reconstruction in women. So Professor Manoharan Murugesan sir is a surgical urologist, oncologist, and chief of oncology surgery at Miami Cancer Institute. He is the chairman, Department of Urology, Baptist Health, South Florida. He is the clinical professor of urology, Herbert Worthing College of Medicine, FIU. His areas of expertise are robotic bladder surgery, HIFU, cryotherapy, nanoknife procedure. He is a renowned leader in the treatment of urologic malignancies, one of the first in the United States to perform robotic bladder removal surgery and also the reconstruction of neobladder. He specializes in minimally invasive cancer procedures, including HIFU therapy, cryotherapy, and the nanoknife procedure for prostate cancer. His areas of interest in research are artificial intelligence, biomarkers, and cancer outcomes. His achievements are more than 175 scientific articles, 20 textbook chapters, and more than 200 presentations. His roles as the leadership of Global Bladder Cancer Consortium and the Global AI Network in Urology. He is active via the Global Cancer Care Foundation, and he's also the member of WHO SIU Bladder Cancer Guidelines Committee. And he got his medical degree from Madras Medical College, Chennai. So I would like to hand over to Dr. Professor Manoharan Murugesan, sir. Over to you, sir.
Thank you very much again, and a very good evening to all of you. And it's a great honor and a pleasure to be here this evening. First of all, I wanted to thank both Dr. Chandramohan and Dr. Soundarya today for inviting. I really follow Dr. Chandramohan more on social media than in real life, and I learned the new meaning for work balance. And one day I will see him posting on a variety of surgical skills, and the next day he'll post something on variety of his dance skills. So that's a new meaning of the work-life balance I learned from him. Then I went to a remarkable person, Dr. Soundarya in India recently, and you're going to be a superstar and icon very, very soon. And today I'm going to, let me, is it okay if I share my slides?
Please.
Yeah.
Yes.
Yeah, good. Let me do that. Share. That's comfortable? You can see it, all right?
Yes, sir.
So thank you very much again. So today I'm going to talk about the intracorporeal neobladder reconstruction in general, particularly in women. And I was asked to talk about some tips I learned over the years. And if I have time, I will also share some of the tips on how to perform a robotic, like a radical cystectomy as well. And so I just want to share my journey as well. And so I might show some of the old videos and I have a change things as well. So I have, sorry, the slides are not, is there somebody is controlling my slides or, okay. So I don't have any disclosures to make. And I work and I live in Miami, and this is my workplace, Miami Cancer Institute. And any one of you are visiting Miami, and please feel free to contact me, and it will be a great pleasure to meet you and host you as well. And bladder cancer in the US, about 55,000 new patients are diagnosed. Out of that, 40,000 are men and about 13,000 are women. And many of you would have seen this slide several times. This shows that since the 1980s, number of continent pouches, particularly orthotopic neobladder, has increased in utilization and number of procedures being done through ileal conduit has come down. That's what this slide shows, right? And also the continent pouches are being less and less. In teaching centers, particularly this is our number in Miami, in men, about 70% of them still undergo ileal conduit, 30% undergo neobladder. Whereas in women, 82% undergo ileal conduit, only 18% have neobladder reconstruction. But if you look at the entire country as the United States, we have a national cancer database, which I've analyzed it several times. We have about 35,000 radical cystectomy patients in this group. But believe it or not, number of people undergoing neobladder is 4.8%, meaning more than 90% of the people still in 2024 are undergoing ileal conduit. So the big numbers you're seeing are from teaching centers that are big centers, but if you take that throughout the country, it is about 4.8% undergo neobladder. So it's not a very common operation, but in the cities, it's much more common. So before I go into the videos and operative points about the neobladder, I just want to point out the differences between the men and women in pelvic anatomy, which all of you know. First of all, in men, we have only two structures penetrating through the general diaphragm, one being the urethra, second is the rectum. Whereas in women, obviously, we have a urethra in the anteriorly, in the midsection, we have the vagina, and posteriorly, the rectum penetrating through the general diaphragm. And a second main thing to know is that in men, whether it's an obese person or a small or a big person, the pelvis is android and it's narrow with the musculature. You have a narrow acute outlet. Whereas in women, again, it's a petite woman or a big woman, again, the pelvis is wide and the outlet is wide open. There is got a significance in terms of urinary continence and other things as well. So another important thing to remember is that the urethra is only 4 centimeter in women, and the sphincter is situated in the midsection, not in the proximal and distal. And most of the sphincter musculature are situated anteriorly and anterolaterally, which is like a crescentic in shape. So if you notice it, this gap between the bladder neck and the urethral sphincter is only 1 centimeter or 1.2 centimeters. That's a normal way. So when you're doing the dissection, you need to be very careful not to go very distally. So the big difference between men and women is that in men, between the sphincter and the bladder neck, the prostate is interposed, which gives a space for us to work on. Whereas in women, the space between the bladder neck and the sphincter is very, very short. You need to be very careful during the dissection when performing the neobladder. For example, if I'm doing an ileal conduit, I go do a dissection of the apex of the prostate extensively and also mobilize the membranous urethra because I don't worry about the sphincter. Whereas if I'm doing a neobladder, I do a minimal dissection of the apex of the prostate so that I can preserve better continence during the neobladder. Whereas in women, as soon as you mobilize the bladder, you will reach the urethra and the bladder neck. You need to be very careful and you need to be very precise. That's the biggest difference. So because of these two differences, and the pelvis being capacious in women, a couple of things you notice is that in the difference in men and women is that with regards to continence, men experience stress urinary incontinence, particularly during the daytime. And nighttime is also like you have a significant incontinence in men. Whereas in women, hypercontinence is more common. They might have to. The reason for that is that when you do a neobladder, whatever you do, still it falls back. The angle between the urethra and the bladder increases, leading to hypercontinence needing the catheterization. The bladder neck, as I mentioned earlier, is not at risk for cancer in men compared to women. The need for self-catheterization is less than 10% in men at the moment, even lower at this point of time. Whereas in women, even though they do very well, if you follow them for 5 years or 10 years, 50% or more people need to self-catheterize mainly because of the neobladder falling backwards. And usually you don't get fistulas with a neobladder in men, and it's very, very rare to get a fistula between the rectum and the neobladder. Whereas in women, in the past, we used to have a increasing incidence of fistula between the neobladder and the vagina. But now, with a careful surgery and other things, the things have come very, very low. Now, even in women, the incidence of neobladder vaginal fistula is very, very small. So these are the basic things I want to say, but I mainly want to spend the next 20 minutes or 25 minutes on what all things has happened with the ileal neobladder the way I used to do it. The I started doing the robotic neobladder with the older machine and around 18 years ago. I think like in 2006, I started doing the neobladder. Life has been really difficult at the time, but over the period of time, I'm able to change only a few things, about 4 or 5 small things. And since then, the surgery has become really, really standardized. You can reproduce it, and then anybody can do it in a systematic way. So that's what I want to share today, what all things I learned. The first one, I'm talking about like 15, 18 years ago, we used to suffer how to transpose the left ureter from left side to right side. Open procedure, we do with the blunt dissection very easily do it. What all things we have changed. Secondly, all of us, including myself, I wanted to reproduce what I did open procedure into robotic procedure. So meaning I do the bowel dissection, do the neobladder, put it back. But that I suffered a lot because the bowels are moving, the patient is upside down, and handling it's very, very difficult. Third is an extensive amount of suturing. When you're doing an open procedure, you keep suturing. Whereas in the robotics, you place the suture, you have to pull back the camera, pull back the instrument, tighten the suture, go in with the camera, go in with the instruments. Every stitch, you need to do 3 steps more. And it will used to frustrate the surgeon. It used to take a lot of time. Be honest, like in 2006, it'll take to 7 to 8 hours. Now the cystectomy neobladder, you can do it in 4 hours or so, or 4.5 hours, you can do that. So we are able to change small things and able to make significant progress in the way we do this. If you're doing the neobladder for the first time, before you start, try to watch as many videos as possible and mentally imagine how you're going to do it. And also assist as many as procedures as possible. This is mainly for a younger urologist trying to attempt doing a neobladder. Certainly, you need to familiarize yourself with the open procedure, which will gives you understanding of the anatomy and steps, and be prepared to, for example, you're doing the procedure upside down and the patient's under pressure. If you're taking long time to do the procedure, you should be mentally prepared to convert it and do it as an open procedure if needs to be. It's difficult as well. But most important thing I want to say is that when you watch good surgeons, don't fall into a good surgeon trap. These people have gone through a lot of things and they make the procedure easy, whether it's a prostate or a kidney or a bladder. The good surgeon will make the surgery look very good and easy. That gives you a false confidence that you can do it very quickly and you're going to get into trouble. Instead of that, learn all the good techniques they are doing, try to reproduce it. This is important to know as well. And before you start again, first of all, you decide what are the suture you're going to use staples, what length you want, what size. Pre-cut them, keep it ready for you. Similarly, you need bowel instruments. There are a number of bowel instruments are available. You have a Cartier, you're a tip-up, you have a DeBakey. You decide what instruments you want and certainly educate the team, the surgeon, assistants, bedside assistant, nursing staff. And another thing I used to do, I don't do it now, is that the steps, what sutures I'm going to use in the order, I write it in a sticky note, put it and stick it in front of the scrub tech and the nurse so that she knows, okay, he is using this stapler now. Now he's going to ask for this suture. So she'll know and she will get it ready for you. Each step will cut down 15 to 20 seconds if they're well prepared. And I used to share this funny story with everybody. I made one fellow to count. There are 298 exchanges happen between the surgeon and the nurse during the cystectomy and neobladder procedure. And during these 298 steps, if you save 15 seconds each, that alone will save about 2 hours of the surgery. So you need to be mentally prepared, prepare the team, and the surgery will go smoothly for you. And the first tip is that unlike prostate and the kidney, this is a longer procedure. Patient is going to be upside down for a longer period of time. So make sure that you position the patient very well and all the pressure points are maintained. And I'm not going to go through everything. I'm just going to go through about 4 or 5 small things which are useful for the surgery. The first important thing to know is the port placement. I'm going to share what I do. And I use XI, but I started with, I started the original robot with 3 arms, then S, SI, X, and the various things. But normally we have a camera in the midline, like a prostate, but I use a left-sided assistant, meaning that I have 2 ports on the right side and one on the left side. And the reason is that on the right side, I have a scissors and I have a grasper. The third port will be on the right side, which will have pro grasp. The idea behind is that you have 2 graspers on opposite sides so that I can use it at the same time. I can use 2 graspers to move the bowels and various things. And because of the fact that the mesentery of the bowel is along the belly button here, not down here, if you put the ports here, you won't be able to handle the mesentery of bowel. So you need to move all the ports up compared to the prostate at least by 2 centimeters so that you can handle the bowel. That is important thing to know, that the port should be much higher around this plane rather than just like a prostate. Secondly, I use a 5 millimeter port in the left upper quadrant, and then I have an air seal port at 12 millimeter port, just 5 centimeters above the anterior iliac spine, because through this you're going to use the staplers, and with the staplers you want to handle the bowel resection, etc. Here, if you have the air seal port on the right side, or staplers, it's very difficult to reach the mesentery nicely compared to left side. So these are the main reasons. But the main reason I do the left side port is that, this is a recap of what I said. So the port should be 1 to 2 centimeters above the robotic prostate ports. The assistant should be on the left side, which is preferred by me. And the 12 millimeter port should be above the 5 centimeters above the anterociliac spine. And I normally use the air seal device. So why do I do that? Why do I have a left side compared to right? Because most of us are right-handed surgeon. More importantly, most of the assistants are right-handed. So when let me put the ports here again. So these are the ports, and then we have this one and that one. But the assistant is going to sit here. When the assistant on the left side, his shoulder and other things will be like intuitive to assist from there. And with the various devices, clips, suction, staplers, many things, you can reach both the right side of the pelvis and the left side of the pelvis very easily without hurting the shoulder or twisting the shoulder. And it's very, very easy for them to do it. That's one of the main reasons. Second main reason I told you is that the graspers being on the opposite side. If you have the grasper on the same side, you can use only one grasper at a time. Whereas in the cystectomy, you got to use the bowel on both sides. You have to grab it. And one more thing is that as a young surgeon, you should become less and less reliant on the assistant. You should be able to do most things yourself. It's a very easy movement, but this is possible only when you have a grasper on 2 sides, not on the same side. And otherwise, you have to rely on the assistant to grab once, you grab once, it makes it difficult. So that is the main purpose. Again, the reason for the left-sided is that it is very intuitive for the right-handed assistants, comfortable with shoulder. 2 graspers can be used at the same time being on the opposite side, and we can reach the pelvis on both sides easily. And again, the port should be higher. This is my take on how to place the ports and where to place the assistants. What I can do is that I'll do the entire talk, and then probably I'll answer questions in the later point. So now, when I'm teaching the residents how to do a neobladder, teaching the fellows, I divide the procedure into 8 steps. And they will be doing each step at a given time. And they master one step, they move on to the next one and next one. So at the end of their training, they'll be good with doing a neobladder comfortably in a standardized fashion, which should be reproducible. First step is the transposition of the ureter. And during the next 10-15 minutes, I'm going to show you what I did many years ago, meaning 15 years ago. So the video will be less quality, and what we do like the last 5-10 years. So you'll understand how things have changed a little bit. So first thing is that before you start the neobladder, decrease the Trendelenburg position. Normally, many of you do the prostate or a cystectomy at a 26 degrees or 28 degrees. Bring it down to 15 to 20 degrees or less strength, and then get all your sutures and staplers ready, and again, educate the team once again. And it's very easy to undock and dock the robot with the newer devices. So the first thing is the transposition of the ureter. And in the open procedure, it's easy. You lift up the sigmoid, you can even put your fingers underneath, and then you bring the ureter out. But in the past, we really thought like we're scared of the aorta, iliac veins, common iliac, and IVC, etc. We used to do it very, very carefully, used to take time. But in the past, we used to do extensive for dissection. Now we don't do that. So there's change, things have changed. But I suggest three things. I'll show it in the video as well. First of all, when you're doing the left ureter, you mobilize the ureter, whatever you are going to do when you're doing the cystectomy, but keep pushing the sigmoid from left to right towards the midline by blunt dissection. Lift up the peritoneum and push it and leave it there. Similarly, when you're doing the right ureter, lift up the peritoneum, push the sigmoid from right to left. So both sides you're doing it. When you do that, the sigmoid becomes mobilized quite easily. By blunt dissection, you can easily, one or two moves, you can go from the left to right side. You'll see it in a second. But the sigmoid mobilization in the prostate, you do mainly for just releasing the adhesions and access. Whereas when you're doing cystectomy, the sigmoid mobilization has got three purposes. Purpose number one, you release adhesions. Number two, you're going to find the left ureter and mobilize. But the third thing, as I told you, is to, when you're doing it, lift up the cut end of the peritoneum on the medial side and mobilize the sigmoid just by blunt dissection with the grasper. Keep pushing, pushing, pushing. You do them all, that helps you. So three things: release adhesions, find the left ureter, and push the thing. You get it ready for future to mobilize the left ureter to the right. So this is nothing major in this video. This is just to tell you the steps that the purpose of that. Then this video I want to show you is that this is about 15 years old. And when we did that, we did extensive lymph node dissection. We are told to do a pre-sacral lymph node dissection, everything. When you do that, the sigmoid automatically gets mobilized. So then transposing the left ureter to right is very, very easy. But that is not the case in the modern days. Modern days, you don't have to, or our current guidelines don't expect you to do very extensive lymph node dissection. So that in that situation, say here the whole sigmoid is mobilized, pre-sacral nodes, everything is done. So you can see the sacrum there. All that you have to do is that put the ureter underneath that and bring it out on the other side. So it's not that difficult because you've done extensive work on the pelvis. Whereas in the modern days, you're not going to do that. Just note this peritoneal edges and that peritoneal edge. So now the both ureters have come out. You can see that how easy it is. That is because you have done a very extensive lymph node dissection. But most of us, and I don't know about what we do in India, now we don't do extensive lymph node dissection during cystectomy, which means that we have to do small tips. So this is the current way we're doing it here. This is the peritoneum which I divided before. With the third arm, hold this peritoneum, lift it up, then do a couple of blunt moves. Similarly, hold this peritoneum here with the third arm, and the sigmoid is lifted up anteriorly, and do a couple of blunt moves, and you'll be able to easily get the left ureter to the right side. Again, these videos are not edited, which means that this is what you see in real life as well. This is the left ureter already mobilized before. Third arm is lifting it up. And then all that you do is that just push a couple of times, once or twice. Then go to the right side, again, divide the peritoneum. You can see the third arm is lifting up the peritoneum here and just go loose air tissue and then keep pushing a couple of times. Now the sigmoid is mobilized. Again, this is unedited. You can see the timing it takes. It doesn't take much time. Using the grasper, just go underneath, and then one or two moves, you will easily get underneath. The key is to lift the sigmoid up and do it so that the iliac veins, IVC, various things are not at risk at all. And now here it is. That's it. The two moves are done, and you come here, and the ureter is given, and then take it out. So it's a very simple move, but 15 years ago, we used to struggle, but now it's reasonably easy. The most important thing is once you've done both the ureters, secure the ureters somewhere in the corner in the right iliac fossa so that it does not flop around. So that's the first step we teach. And then comes to the second thing is that bowel segment selection. Again, once you're experienced, you can use an instrument to measure it. But in the beginning, you need to be very clear what segment you're taking. So I personally, I use 55 centimeter long, the small intestine, the ileum. I use about 40 centimeter for the pouch. That gives me about 200 cc capacity bladder, which in 3 months becomes 350. In 1 year, it becomes 500 to 600 cc. And I also use a 10 to 15 centimeter chimney, just like a Studer, but it's not a Studer, it's not a Harman, it's just a combination of both. And you'd always need the chimney. I'll tell you why I feel the chimney is important. If the patient live long enough, they can develop urethral recurrence. They can develop some complications. You might have to convert the neobladder into ileal conduit. If you have the chimney, you can disconnect the chimney from the neobladder, flip it as a conduit. If you have a doubly pouch or something like that, if you want to convert a neobladder into an ileal conduit, you have to redo the whole thing. It becomes a very, very tricky thing. That's why it's important for us to know that chimney's purpose is not alone for the reflux. It also allows you to convert the neobladder into conduit very easily. You don't have to touch the ureter. You don't have to do anything else. So the bowel, we start from 15 to 20 centimeter from the ileocecal valve, and you need to measure the mesentery. And you need to measure the bowel length, but more importantly, you need to assess whether the mesentery will reach the urethra or not. These are three things you do when you select the segment. Again, 15 to 20 centimeter from the ileocecal valve, measure the segment. You can do 60 centimeter, 55 centimeter, whatever you want, but measure it, then assess the mesentery length, whether it's going to reach or not. Now, this particular video, the old one, you can see the appendix, cecum, and using the bowel graspers, you hold the bowel and try to see whether they're going to reach down. But here, what the difference you're going to see is that I want to replicate the open in 2006. So I did the bowel resection first. So the entire neobladder segment is flopping around. So the assistant has to hold it. I have to hold it, change the hands. So many sufferings were there. And it was very, very difficult for us to do it, but we did it anyway. But it was difficult. It's difficult for young people to do it. So you can see that this particular video, like many people need to hold it. And I used to use this instrument to measure this 5 centimeter, and I use that. But in reality, for a new surgeon, you can't use the instrument to measure it. So I use a stay suture. I cut the stay sutures 25 centimeter, and from ileocecal valve, I measure it and I find where the 20 centimeter is. Put a suture from there, put the stitch on the bowel, keep measuring that. So I use the stitch itself as a measuring tape. So this patient already had a cystectomy done, and we are doing it. So you can see once again, the two things you'll see is the cecum is that apart from the appendix, you see a fatty tissue like a comet's tail at the ileum tells you this one we are ileocecal valve. From there, you're going to measure. So I use a vicryl, and first I'm checking whether the bowel will go down. So I'm satisfied the bowel will go down. And once I know that, I'm going to use a vicryl stitch and take it from about 20 centimeters from the ileocecal valve as a stay suture and keep it there. And I lay the suture down all the way along the bowel because you don't want to stretch the bowel and miscalculate the length, and you don't want it too long and too small. So I just lay the stitch on the bowel so that I know that this is 20 centimeter. So like that, I put sutures at the apex of the neobladder, proximal of the neobladder, and the distal of the neobladder. Now I'm clear what I'm doing. Once I put the stitch, I just cut the stitch so that I keep cutting it. So this one will be a proximal end, the other one will be the apex, the another one will be the distal. So you can put 3 stitches. Again, these are all for beginners, not necessarily. So this is the apical part. Now I'm checking one more time. Are we able to go to the urethra or not? So this one I'm able to reach comfortably. I'm very, very happy now.
Sir, sorry to
So,
interrupt.
yeah.
The apical stitch which you are taking is how many centimeters from the first stitch, sir?
Sure. So basically, the first stitch is about 20 centimeter for the ileocecal valve.
Okay.
Then my pouch is going to be 40 centimeter.
Yeah.
So the apex will be 20 centimeters from there. So first stitch is 20 centimeter from ileocecal, and the apex will be another 20 centimeter from the first stitch.
Got it.
So you'll have afferent limb 20 centimeter, efferent limb 20 centimeter put together as of 40 centimeter length. So there'll be like a U pouch. Then I have a chimney as well. So this step I'm showing you is that how what I'm going to do next. The next step I'm going to show you, I thought about it. I just did that once. That changed the way the neobladder is done. Meaning, before that, I was doing like an open procedure. I will divide the bowel, create it, and bring it down. But now, upside down, we did that. What I did was we stitched the apex without doing bowel resection, without doing anything, simply to the urethra, behind the urethra. Once I did that, the entire bowel segment neobladder got fixed. It did not move at all. Nobody needs to touch anything because patient is upside down. I fixed the apex. Everything is okay. That one simple step really change the way the neobladder is done, cut down the time quite a bit. So you're going to see this. So what we are going to do here is that I'll show you the steps. Is that first, once you identify the apex of the neobladder, I took it down just like a Rocco stitch, fixed it underneath the urethra. So the bowel got fixed. That allowed me to do the bowel dissection in a stable way, nothing moved. But I also, next I did was, I did the anastomosis between the neobladder and the urethra when everything's clean. Again, that cut down the time quite a bit. So this is what we did. I think this might be the old or new video I need to see. So this is the new video. I'm just taking it down. It's a continuation of the previous video. Take it down there. So I know where the stitch is the apex. I took the 3-0 V-lock suture, go to the anti-mesenteric board. You cut the stitch up. And just like a Rocco stitch, you take it down, go under the urethra, and I sewed it there. And it looks like a very simple stitch, but before I did that, it was a very, very difficult for me to do the neobladder. This one stitch made it easy, both for me, for the fellows, and the resident as well. And you'll see that this, I think many of you do a Rocco stitch. I think it is just similar to that. And you will see that like once I've done that.
One doubt, sir.
Yes,
Do
sir.
you think that, sorry, sir, generally I interrupt
Yeah.
because the
No,
people,
no, please go
a
ahead.
lot of nearly 100 people, more than 100 have joined. When you take this stitch which goes down in the before the bladder, before the ileum is opened, sir,
No, nothing. I've not done it. This is the first step of the entire neobladder.
in that
So
case, while manipulation a little bit, won't it get torn, sir? You have to be careful.
no, like
Keep in mind that something is struck, entire bowel segment of 40, 55 centimeter has to be handled against some pull, while opening the bladder, while opening the intestine, while suturing the medial walls of the intestine. There can be a traction on this. I'm just
no, actually, it's a. Thank you for raising that question. It's actually totally opposite to that.
okay.
Because with this particular procedure, you actually don't manipulate anything. And you'll see it in a second. So it's a counterintuitive to what we think, but because now it's fixed there, you can see that the pelvis is clean, no bowel is moving. You'll see it in a second.
Yes, sir.
And you are not going to manipulate the bowel too much at all. When you do the bowel dissection first, if you manipulate like a bowel like a 10 times, here it'll be just 1 in 10 moves. You'll see it in a second. So the first step, if you do this, remember the patient is upside down, all the bowel is fallen down, and the pelvis is clean, just like this. In real life, whether it's a male or a female, you'll see it exactly the same. So this is the first step I do. And now the second step is that this is the urethra. This is where the neobladder bladder neck will be there. And I'm going to do the anastomosis next. So this is the same thing. So now, when you have this clean view, nothing is touched, nobody's moving anything. If you notice that assistant is not doing anything there. And I go closer there, just like a prostate. You grab the thing and you, like I use about 22 French or 24 French catheter. I just make an opening just for the size of the catheter. And then, just like a prostate, I use a 3-0 double arm suture. Either you can tie it together, I can use the double arm. And I'm going to do the urethral anastomosis and the neobladder. That's the first step. If you notice it, it's totally opposite to what we do as an open procedure. By doing this, the entire pelvis is clean, and I'm not really relying on anybody to hold the bowel or maintain the traction or anything like that. And I'm able to do the anastomosis in a clean, in a very peaceful manner. And it's quite straightforward, just like a prostate. So again, as Dr. Chandramohan asked, I have not touched the bowel. I've not done anything to the bowel yet at this point of time. And I'm just doing the anastomosis now. So the last part of the surgery is done first, and that has really made a big difference for us. And you can see that the entire anastomosis is done just like a prostate, and all of you are familiar with it. And there is no difference between the anastomosis between the prostate as well as in the cystectomy. So the anastomosis is complete. Let me go through one more couple more seconds. I think so the anastomosis is completed, and again, the bowel is extremely stable. Nothing is there. Because remember, the patient is upside down. No bowel falls into the pelvis. They're falling towards the cranium. So it's very clean. So we are done now. So next, what we are going to do is that we are going to do the bowel resection. So this is the olden way. I just want to show the thing is that about 15 years ago when I did this, and I used to suffer because, again, I need to pull the bowel after doing the neobladder. I have to do the Rocco stage. I need to, pull the bowel down. And it is difficult at the time. We were able to do it, but just took a little bit more time compared to the current way we are doing it. So we don't do it this way, but I want to show you how things used to be those days. Next is the bowel resection anastomosis. Again, I'm repeating myself repeatedly because I'm comparing. In the past, so the bowel will be hanging around And if somebody has to hold it, assistants hold it, I have to hold it, then stapler, then bowel falls down, sometimes falls towards the chest, and you need to grab it back and manipulate the mesentery, etc. Whereas the way I've just described, nothing is going to move, and we are just going to staple and do the anastomosis, and you will watch that. So before I do the bowel resection, I use JA stapler. You can either use the manual through the assistant, or you can use a robotic stapler. The way I do it is that because I want to avoid, like a stricture and other things, I do side to side anastomosis, stapling twice, and then I traditionally use the same JA. Then I close the mesenteric rent with 3O silk. So this is the whole way again, and I'll be very quick. Again, somebody has to hold the bowel, somebody has to manipulate all these things, etc. But whereas in the newer way, what we are doing it, I think this is what Dr. Chandramohan is asking. This is a real view. This is anastomosis done. The bowel is there. No assistant. Nobody is doing anything. Bowel is remaining stable. So I've already placed a stay suture. So the proximal suture will be here. Distal part will be here. Chimney will be around somewhere here. So you have to resect only this part, and no bowel is there, and I'm not going to manipulate anything. You'll watch this. So this is one stitch, the proximal stitch. And I'll make sure that I got the 20 centimeter each side. And again, sometimes I have two sutures put in so that I can hold it up, and you don't have to do it. I'm just showing it to you. And I'm only manipulating the part of the neobladder. The rest of the small bowel loop mesentery, if you notice it, there's no stretches happening. Whatever stretch for the neobladder has happened already. So now I think I'm placing the sutures here. This is the chimney part from here to here. And normally we put it beforehand, but now you can see that there are two stitches. There's nothing major movements are happening. There are two parts he is holding it. The key thing here, I'll show it to you. When you're doing the stapler, you should be perpendicular to the mesentery. That is the only point I'll make it, because in the 2D and 3D, this mesenteric thing, you can move that way or move that way. It'll be good. So always make sure that the stapler goes in a 90-degree angle to the bowel. That way you are very, very safe. And I think the manipulations only happens around where you're resecting. You don't touch any other mesentery, any other bowel. It's only about 60 centimeters. So 3 centimeters for the bowel and 3 centimeters for the mesentery happens. That's all the mobility happens. So you can quickly resect it, and you have stay sutures on both sides. So, and you do the same resection on the other side as well. And the manipulations are very minimal for the mesentery if you notice it. And again, the stapling thing happens. I use Ethicon, but you can use anything you want. You can use a robotic stapler as well. So the manipulation, in my point of view, it's a very small. And now the neobladder is completely, separate from the bowel. These two are the bowel segments. So now you have these two bowels, which needs to be restored continuity. But remember, when I'm going to come in with a with a stapler from the robotic port, the two ends are not separate. You only open it like that. Okay. So you need to keep it like way, and the bowel has to go in. So these two bowel segments should be free. If you put a stitch bringing these two together, you cannot separate them. So the first stay suture
Again,
approximating
sir,
should
again,
be.
I will ask a question here. We
Yes,
face
sir.
a little bit of problem in this. We do a bit of robotic now.
Mhm.
When we don't take the two stitches around 10 centimeter distal to the distal or proximal to this end, when you put they are actually big. The two stapler wide width is big. When you are entering, you need something to push. One you push it, other will sleep. The other you push it, other will sleep. Both will come. So distally we ligate both of them. They can pull it. But when you close it, if the other ends are not together, sometimes it goes more towards the mesentery, and so it may not be in the center, so that a proper lumen at the antimesenteric border may not come. So we face little bit of problem here.
I'll have a small trick for that in a
Yes,
second.
sir.
I'll
Yes,
show
sir.
you in a minute. So
Please.
before I show the next video, so this you need to put a stay suture, small one, not big one, just on the the mesenteric border here and the mesenteric border on that side. So just two stays, and then you're stapling it. You divide the bowel. Now the bowel is ready to be anastomosed. That's when you're having that. The question is about. I think Dr. Chalaman is asking for the audience purposes the problems we are facing. what I'm just repeating the question Dr. Chandramohan is asking is that, so these two bowels we are going to anastomose. When you put the staples, it slips, and also it's not in the anti-mesenteric border. How to resolve that question? That is the question it's asking. So remember, we are putting the stay sutures. You put them on a mesenteric border on this side and mesenteric border on that side, and just leave it like that. And let me show the next video. So what happens is that here, what I mentioned is that this is a stay suture. It should be 6 centimeters from the tip, from the staple line, and approximate them. This will be for the first stapler. We are going to do that. That's the first stitch. You don't put the stitch on the staple line closer to it because you need to separate the bowel segment. This is the first stay suture. And then the second stay suture will be 6 centimeters below that. So these two will be on the anti-mesenteric border. Okay, so that way the bowel becomes stabilized first. So that's the first thing you do. And so that way, this is where the anastomosis is going to happen. And so the second, let me stop it for 1 second. So let me go back. So the segment from here to here is free. They're not attached to each other. That way they can go into the staple line. So the first stay suture is 6 centimeters, second stay suture 12 centimeters. Then you open the thing. And so now when the staple comes in, the assistant puts it here, and with the thing, you pull it up, you hold it, you bring it up. And then the second one comes up here. There is a stay suture you can place here, Dr. Chandramohan, here. The assistant can hold it there. And you can see that the stay suture on the anti-mesenteric border here and here allows you to put the staple line, and you can pull that staple line up. The staple will go along the anti-mesenteric border rather than slipping to here. So this video did not answer the question completely for you. However, what it wanted to say is that put 2 stay sutures at 6 and 12 o'clock, 6 and 12 o'clock. Secondly, leave this segment completely free so that you can move around. And in the beginning, if you also want to put a stay suture, the video. Yeah, if you put the stay suture here, the assistant can hold it with a grasper so that this segment does not slip out of the stapler. These are things you can do. I hope I'm being...
Again, the stay stitches, because slightly you are faster, sir, if you don't mind. The stay stitches at the open ends should not be taken together is the meaning you are telling. They should be taken 6 centimeters away from it so that they can be open and handled to enter into the stapler. Is it correct?
Yeah. Absolutely correct.
Individual stay can be taken so that assistant can pull the individual stay line.
Sure. So, for example, if the concern is about, because unfortunately my assistants are very experienced with this, they're very good with this thing. But if you're doing it as a new assistant, where this is holding here, put a small stay suture here. When the first bowel is put in there, the assistant can come with a 5 millimeter with a grasper, hold the stitch and hold the bowel there so that it doesn't slip out.
Yeah.
And then you can put the other one and they can grasp it. So 3 things that we have told you. So I'm just repeating because the 20 minutes I was trying to rush, but I'll try to be slower now. So from the edge to 6 centimeters, don't do anything. Leave it free. First stay suture comes along anti-mesenteric border at 6 centimeters, and another suture here at 12 centimeters. Then open the bowel. And in the beginning, you can put a stay suture here so that once bowel segment is in the stapler, the assistant can hold it as well. And so that the bowel does not fall out. The second thing comes in, and then you close the stapler and you can staple it. And if you want, you can lift this stay suture up so that the lumen is open and you can manipulate the grasp.
Great. I understood, sir, completely. Great.
Thank you. Sorry, because I had 30 minutes, I thought I was just trying to rush. That's all.
No problem, sir. Actually, this is a documentary forever, sir, in the YouTube.
Yeah.
From next minute after.
Oh my God, no.
Lifelong it will be there. So you are giving a lot of the knowledge to all those who wanted to see after 10 years also, they will see this. So that's why I'm interrupting. Sorry, sir.
No, I would like you to interrupt me as much as possible. So the third point is that now we have the open thing here. Remember the robotics, you cannot use a TA, the transverse anastomosis stapler. You need to use only GAA staplers. Either you can close it with sutures, but I'm lazy, I use stapler. So if you hold with a grasper, this edges up, you can use a stapler and you can fire it. So I'm just holding it, and with a stapler, you can just close it. So the anastomosis is done. And usually, if you have an experienced assistant or a co-surgeon, you just need to do this. Then I'm going to close the mesenteric rent. Using the bowel grasper, I hold it, and then I just close the mesenteric rent from, this is the mesenteric rent, I close it. That one belongs to the neobladder. Don't make it too tight at the end because then the neobladder cannot be manipulated that easily. Just leave little space there, but the whole neobladder comes together. So now we are ready for the neobladder reconstruction. So I take these two sutures and pull it up. I'm going to stop here for a second. Oh, sorry. Let me go to the next thing. So now the next step is you're done the bowel resection, bowel anastomosis done. Now we are ready to do the neobladder. So neobladder is already attached to the urethra, and all the bowels fall back into the abdomen. The pelvis is clean. All that you have in the pelvis is that ascending limb, sorry, the efferent limb and afferent limb and the chimney. That's all will be the pelvis. That is the beauty of the way I just described it. I like it, so that's why I'm promoting that. So the standard pouch, the chimney will be about 10 to 15 centimeters. The pouch is about 20 to 25 centimeters on each side. So that put together, you have a posterior wall 25 centimeters, anterior wall 25 centimeters. You have to sew about 50 centimeters. And I used to use a 3O V-lock before. That was too small. Then I started using 2O V-lock, the little bit bigger needle for the closure. But what I did here today is that I started putting stay sutures. I'll show it to you. That made the procedure very simple. Remember, I told you suturing the neobladder used to be very, very painful for me. All the simple thing I did was the 20 centimeter length of the bowel, I put stay sutures every 5 centimeters. So I have 4 stay sutures. When I have stay sutures, your third arm will hold one of the stay sutures. Assistant will pull the bottom stay suture. The suture line becomes straight, and I'm able to throw sutures like an open case. So in the past, I did not put stay sutures, but now I put the stay sutures first. Things are very, very easy. I'll show it to you as well in a second. So this is the old version of it. Again, I'm just showing you what all the things I've changed. So this one, if you notice it, this is just a suture to tell you where I am. But here, like I'm not using any stay sutures. I'm just opening it. As I open, the neobladder wall becomes really floppy. And here the assistant is holding one and I'm holding one. Assistant uses suction to pull the things. So the 4 people need to use, still the bowel will be flopping. This is how I used to do in the past. But now what we do is that before we do this the detuberization, I place a stay suture. See, this is a different limb and the front limb going to make the pouch. So this is the apex. I put one stay suture here, 5 centimeter per second suture, third suture, 4 sutures. There's 4 sutures are there. And once I do that, the bowel is stable and you open it up and then you'll see what happens here is that makes it easier for you. So you can use anything you want. I use a 2O Vicryl. Just place a stay suture closer to this thing and it takes about 2-3 minutes. But if you do that, it makes your life easy. And when you cut the thing, you don't have to have a very long thing, just a small thing. Here it's a little bit long, but tiny weeny stitch is more than sufficient. Now the neobladder is together. It's not going to move or go anywhere. It's very, very stable. And once it's stable, so the idea is to the assistant can hold the stay suture and I'm opening the neobladder now. And with the third arm, hold one arm. And so the assistant is mostly like sucking the smoke and there's no need for him to hold anything at this point of time. So the neobladder is open all around, the anterior wall all around both ways. So the neobladder is completely open. Once it's open, you will notice that the posterior wall is already stitched together partly by a stay suture. They'll be making a straight line. And this is one side is done. The point I'm making is that as a surgeon, you become less and less reliable on the assistant. You need a good assistant, but become less reliable, and that'll make it life easier. For example, the third arm is holding the stitch, so the assistant is only sucking the smoke. So he's not actively participating. So whether you have a very experienced assistant or a little less experienced, you can still repeat what you're doing in a nice way, and you can just keep doing it. And again, don't use cutting current. Cutting current will lead to a lot of bleeding. Use a coagulation current. And I'm going to stop here for a second. So
Sir,
now
one
you're
more doubt, sir. In the
Yes.
first 2 cases, we have used a Caesar, and somehow even with coagulation current, lot of bleeding and a messy field was there. Now we are using the ligation and continuously cutting because bowel is very vascular. Is it okay, sir?
Right. Oh no, that ligation is a bipolar device. So
Bipolar.
the burn effect is that you can certainly use it. If you're having a smaller ligation device, laparoscopic ligation device, that's what you're
Yes,
using,
sir.
I
Yes,
think.
sir. Yes, sir. Yes,
And
sir.
it'll be very good. Nothing happens.
Yeah,
It'll be very, very useful for it. So the only thing is that I don't use a ligation is that because I want to use everything myself. And I'm not relying on the
I just
assistant.
feel
I
it should
think the
be done by the
ligature.
assistant. Correct, sir. Correct.
Correct. So because I have residents, I have fellows, so I want to do it myself. And if you use the 3 or 4 setting of the coagulation current, and the key thing for not bleeding is the stretch, sir. If you stretch hard and then do it slowly, the coagulation will work. But if the bowel is not stretched fully, if you coagulate, it will bleed. So the ligature device, again, the assistant base, that's why I don't use it, but very well you can use it if your assistant is very, very good. But I think there is a key thing. So now, this is what we used to suffer. I want to tell for younger people that I said that earlier. When you're doing open procedure, you throw the stitch, pull it up, throw the stitch, pull it up. Okay. So if you're having a 50 centimeter length, each stitch you're putting 3 millimeters apart, you need to throw 150 sutures. You need to remember that in my heart. You're going to do the
Yes, sir.
same thing again and again, 150 times. This is the most boring, difficult part. At the same time, if you mess it up, you're in a leak. So you can see everything is against you. So we need to make sure that everything is going to go very well. So how to make it easy is what going through my mind. And so again, I want to be less reliant on the assistant. So now the stay suture really plays an important role for me. So hopefully you'll show that. So there is a stay suture there, or I think I use the third arm to, lift it up. The assistant is holding the other suture here. So you can see the assistant. So the line becomes straightforward, and we can do this very nicely. The posterior, this is deterioration. Sorry, I think I'm using the same video. So this is okay. This is the old version of the way I think how I used to do. See, you can see that this is 2007. Okay, and you can see that I'm doing slowly. I'm worried about what is going to happen, etc. Whereas now, posterior wall reconstruction, the stay switches are placed already, and you saw that already. And this is real thing. And we have seen all this video, and I'm going to go to the suture. So you can see that the assistant is holding the stay suture, and I'm able to throw the stitch one after another without any difficulty. And if you notice that nothing is holding. Now I've finished the first part, and the third arm grasp this stay suture. Assistant is holding this stay suture. The line is straightforward. And just keep changing the hands, move from one stay suture to another, and you can keep going. And gives you a clean line. You can see it here better. You have a clean line of suturing,
One
and
more
you
doubt,
don't
sir.
have to. Yes, sir.
In bobbed suture, if you take
Hmm?
multiple 4 bites without pulling, and while holding at the base and pull gently, does it produce seesawing effect and tearing of the mucosa, or you are taking every thread you are pulling, but 3 bites, for example, proline monofilament, we do five stitches and pull it. But we are
Correct.
using bobbed. Can we pull like that?
So that basically speaking, the switches we are using is for example, like a 2 or a 3-0. There's one, for example, if you're using 2-0, in reality is 1-0, right? Because that's Bob's is there as well. But the bowel with serosa is a very tough structure. You can pull it, but I'm worried about whether I pulled it correctly or not. I try not to have 3 or 4 stitches. Either I pull every stitch or every 2 stitches I pull. I don't pull after 3 or 4 stitches, mainly because I'm worried about what if the 2 stitches get tightened, the one is loose, the urine will leak. So because of the
Similar
watertight
question,
thing,
sir. Similar
sorry,
question.
yeah.
Similarly, when you do
Hmm?
Roca stitch, previously we used to take one bite and pull, then it cut throughs. So the people take 4-5 bites on either side. Slowly they do the parachuting effect there. So that, of course, they don't pull the suture. They adjust again one string, one string, one string like that. There, probably they say that if you pull one bite, then it may cut through. They will take 4 bites on either side loosely. Roca stitch. I hope you are understanding, sir.
Yeah. So you're talking about the prostate or here, sir?
No, sir. The pulling of the barbed suture more than 3-4 times after taking 3-4 bites. Is it safe or not recommended? That's all, sir.
No, I think more than 2 is not very safe in the urinary system.
Okay.
The reason I'm saying is that not tearing alone, the 2 of them will get, a tight. The third one may not be tight.
Okay.
So that's what I'm
Okay.
worried about.
Okay,
And
sir.
the urinary leak. So basically with the barb sutures, more than 2, I don't prefer to
Okay,
pull
sir.
it.
Got the point.
Yeah.
You mean to say that
Yes.
first 1 or 2 may be loose, last 2 may be tightened.
Right. So next time, with particularly the younger surgeons, when you're doing a prostate anastomosis, when you parachute it down, the first three, when you tighten it, you look back again, the first stitch will be loose, the third and fourth will be tightened.
Okay.
You need to look at it yourself, and then you'll
Great.
let it.
Great.
So here, again, I hope the younger people understood that the usefulness of the stay suture. The stay suture, the third arm will, you hold the distal stay suture, assistant will hold the proximal, pull it hard, it'll be a straight line, and you can throw the sutures again and again. And also, younger people also can do the same as well. So I'm going to stop it here for the moment. And you can tell me the timing as well, like if I'm taking more
No
time,
problem,
and
sir.
just tell me
Time
when to
not
stop.
all issue. You carry on,
Yeah.
sir.
Sure. So now, because I'm going to talk, I wanted to say something about the cystectomy. I'm going to move a little bit faster as well. So the ureteral anastomosis, I'm not going to spend time because it is just as a standard thing. Once you have done the neobladder, both the posterior wall and part of the anterior wall, then go to the chimney to do the anastomosis. What I do is that I close the staple line with the two ovicle so that the staple line is isolated. And I use Bricker, and I do not know what you what you do, but Bricker, when I do that, I do the anastomosis on both sides. The reason for that is that these patients can develop upper tract disease anytime. They might need nephrouretrectomy. And if you do like a Wallace, if you put both the ureters together, if you need to do a nephrouretrectomy or do something else or a stricture, if you repair it, you have to redo the whole right and left once again. Whereas if I do Bricker, apart from all the benefits, I can just do the left side alone separately, or if there is a stricture on the right side, I do that as well. I normally use a 6 or 7 French single day stent. I use 4 switches for the anastomosis, but after anastomosing, I use the peritoneum to retroperitonealize the anastomosis. These are the steps I do, but I'm just going to skip that quickly because I just want to share some other information about the cystectomy. So this is again the old video, but I'm just those days I used to do a Wallace, but I don't do it anymore. Don't do the anastomosis very close to the distal end because you can stricture. If you have a length, do sacrifice some of the ureter so that you get a very nice vascularized anastomosis. This one I was doing Wallace, but I don't do it anymore. I just want to show you the old one and then take it from there. So this is like some tips I told you about the neobladder formation. But again, the important steps I want to stress is that the port placement higher up. Secondly, left-sided assistant. Thirdly, the anchoring the neobladder before you do anything else to the urethra and doing the ureteral anastomosis gives me a very, very stable neobladder. And using the stay sutures to do the ureteral suturing. These are the 4 points I want to make today. And then we can take it from there as well. And the next thing is that, like, I'll just skip this. So, like, how much time do I have? Like, I'm not sure. It
10
says
minutes, sir.
7:30.
10
Sorry,
sir,
10 more minutes. Sorry, you're muted, I think, Dr. Sharma.
sir, 10 minutes you can finish, sir.
10 minutes. So let me quickly go to this. I'll go to the cystectomy very quickly. So mainly you need patience, that's the main thing. Patience. And every time you do it, you adapt and improvise. And then you need to have a very good bedside assistant nursing staff. So quickly going to the 10 minutes, I'll do my best to do the cystectomy part. And I think Soundari, you asked me to do the cystectomy as well. That's why I'm doing this. So again, every time we divide the teaching process into 8 to 10 steps. So the radical cystectomy, again, I divide them into 8 steps, very, very straightforward steps, and again, reproducible, again, standardized. So I'm going to skip the sigmoid mobilization, but I remember I told you the sigmoid mobilization, you need to mobilize the sigmoid, left ureter, but push the sigmoid from left to right. But most important thing is the posterior plane. And obviously, like people who are doing radical prostatectomy posteriorly know this plane very well, but I want to invest a few minutes to explain this. In doing a radical cystectomy, you don't have to touch the seminal vesicles are vast different. So don't do anything to it. Just do only the posterior plane. Some people reflexly, they mobilize this seminal vesicle. Don't do that. So the steps here are following. First, what I'm going to suggest here is that using the third arm, you're pulling the sigmoid, giving a traction, and it shows the cul-de-sac very well. It's not the right term, the cul-de-sac very well. And when you're doing this, one of the important point I want to make here is that the third arm is lifting up the bladder. When you pull up the bladder, you have two folds. Can you see a fold here and a fold over there? Just like women, you've got a uterosacral ligament. This peritoneum forms a fold. The importance of the fold is that ureters will be lateral to it. So when you're making the incision, the ureters are safe, particularly when you're doing a prostate as well. So you don't have to worry about it. Hold the bladder in midline, lift it up. You see two folds. In between that, you're safe. Don't make small incision. You can make a wide incision. You can do a clear job there. And you need to incise the entire peritoneum completely. And you're doing, again, this is, I think, these are all done by my residents and fellows, and these are all reasonably unedited videos. Not the speed is not. So now we can see the fold I was talking to you about. So the ureters will be lateral to it. As we are doing it here, key thing is this peritoneum is more important, not the upper peritoneum. Using the grasper, give a couple of tugs. When you give a couple of tugs, you will see a loose area tissue developing there, and that is the plane you're going to go in. You need to go in with a camera. You can have a digital zoom, whatever you need, you can see very clearly. So you can see that we are giving a small tug here, and you see the loose area tissue developing, and you need to grab that peritoneum and maintain the traction. Your left hand is more important than the right hand. On small bleeders, you can just bow it, or don't do anything to the seminal vesicle or the vas difference. So as we're going to do this, you need to move the camera inward. When you're starting the career, you forget that. You need to go in with the camera to get a better view. And you can see it is that a lot of people look at my right hand, but it is the left hand which is giving the traction and doing it for you. As you go closer, you will see the deltoids fascia very easily. And then you just do a blunt moves. And the left hand is lifting up the seminal vesicle. Your assistant is giving some traction with the suction, but he doesn't have to do it also. But you need to go in with the camera. And then if you're doing a cystectomy, try your best to open the end of the dermis fascia, go all the way up to the apex. More mobilization you do now, easier it is for you to do a cystectomy at a later point. Once you mobilize the bladder, it's going to fall down. It'll be difficult. So do this. And your device, the whole robotic device is only 7 mm metal part. The tip is only 1 mm. Remember that. It's not a big move you're making, and use the belly of the scissors to do the blunt dissection. Your left hand is lifting up the device, and you, with the right hand, you do sweeping moves like a breaststroke kind of a swimming move, and you keep moving, and your assistant comes in with the suction, and you move in with the camera as well. And all slow moves. There's no need to rush at this point of time. It's avascular. Even if you see it again, you'll notice that even though it looks slower, it takes 2 or 3 minutes only to do this part, or 5 minutes. It's worth investing time. And you can do nerve sparing if you want to. If you don't want to do nerve sparing, it's okay as well. So if you just do the posterior plane, after the battle is won, and don't touch the seminal vesicle. And sir, you tell me when to stop, I'll stop, okay? Then next is the ureteral mobilization. I can do this.
How much time you have for you to leave to the hospital, sir? Because it's early morning.
No, for me, it's a holiday today, sir.
Then we don't stop you.
Let me tell you
Please
something. We don't work on. No, I'm worried about you guys,
No, sir. We are okay. Please, sir.
Sure.
Please complete the radical cystectomy part, because these are very fine tips. See, more than 200 people without paying anything for registration, they are getting benefited. Lot of all over 200 audience is on live. So just the one tip where you said peritoneum, you just pull, I don't know what the word you used. Phenomenal tips you are giving. Amazing. That automatically gives a loose areolar tissue plane, and then you go there. So we wanted to listen, sir, please.
Thank you very much, sir. I was more worried about you. It's a holiday for us, It's not a problem.
For me, no problem. So we are into private practice. We don't have any problem.
Thank you very much again. So, but anyway, I'll try to be brief so that I can answer questions. I thought so the ureter is very critical. So you can do a beautiful cystectomy, but if the patient develops a stricture later, it's a problem for you, So that's why you need to be very, very careful. Again, the idea behind the robot is to make the surgery easy, not difficult. So don't make things difficult for yourself. So there are easy steps to do the ureters as well. Because of the vision, many a times you can see the ureter under the peritoneum. Even if you do not know that, I will show you in the next video the line of the thing. All that you have to do first is to open the peritoneum along the line of the ureter, even if you don't see the ureter. Here, I actually was able to see the ureter over here in the real, here is the ureter going down there. All that I'm doing is that I'm using the assistant very little. I don't want to use the assistant. Sorry about the assistants, but I want to use minimal help from them. All that I'm doing is that opening the entire entire peritoneum all the way up to the bladder first. I've not even touched the ureter yet. And now you can see the ureter over there. Before that, I just want to say something. A lot of people ask me, hey, do I need to learn how to do a cystectomy, whether it's open or a robotic? I'm not going to do a cystectomy. But as in the olden days, it said radical cystectomy and urinary diversion is mother of all urological oncological surgery. If you know how to do the cystectomy or learn few times, you can use this to do a nephroureterectomy. You can use the tricks to do a ureteral reimplant. You can manipulate the bowel obstruction, re-exploration, every single thing. The cystectomy helps. Even if you don't do a single cystectomy in your life, but the tips and tricks you learned in doing cystectomy will help you at some point, including the lymph node dissection. I just want to say that philosophically. And moving on, now the ureter is there. So key thing here is that important thing, and before you do the manipulation, don't touch the ureter at all. That's a key thing. Use the periadventitial tissues. With the 2D, you're not able to see it here, but you catch the tissue lateral to it or below it. Try your best not to touch or burn the ureter at all. That is the most important thing to know. And again, I'm doing most things myself, or a resident is, sorry, this may be a resident and a fellow might be doing, whoever is doing, they're doing a great job. And your assistant is doing a very minimal job. With 2 moves, you will be able to reach the bladder. And usually there'll be one single blood vessel will be supplying the ureter. You can easily burn them and you're ready to go to the bladder level. At this point of time, I used to put clips on both sides and divide it. Then I learned that you don't need a clip on the bladder side. So I put only one clip proximal to it. I leave a little bit of tissue here because I do send frozen section. So if you notice it, I'm telling you where to put the clips, and I will put the clips here. And then you divide it. I just, use the ureter is divided, and the tip, what I have it, I'm going to send it for frozen section. You don't have to send frozen section every single time, but if you want to, you can do it. So this way, what happens here is that this bit of the tissue, you can send it for frozen. Same thing with the left mobilization. The same philosophy. And so here, like a left ureter is not seen, but this is the line of things. So even if you don't see the ureter, it just may open the peritoneum here and then mobilize the sigmoid, you'll be able to see the left ureter. Again, the entire surgery is done by blunt moves, and the burning of the tissue and other things should be well away from the ureter, and you're seeing it very well. This particular step you're doing will be very useful when you're doing a nephroureterectomy as well. Again, here, I'm holding the periadventitious tissue, either me or whoever is doing it, and lift up the tissue, not the ureter, the loose air tissue, get as much adventitious as possible. And then by sweeping moves, if you notice that I'm almost on the common iliac vessels, and by small loose areolar tissue can be cut down with the scissors or cauterize well away from the ureter. And my left hand is giving the traction, not the right hand. And then you just keep moving, and that's all you need to do. And the same thing here, the assistant is helping me, but try your best not to use the assistant if possible. And with small moves, you come to the ureter and you're going to clip the ureter and then take it from there. So now you're done the posterior plane. Now you're done both the ureters, right? Now this is very, very important. We're going to create 2 lateral spaces, but before I go into the video, let me stop it. I want to say something. Okay. After the lateral pedicle, the vascular pedicles taking down with the stapler, ligation is very, very important. The bladder is being held like a hammock between the urethra and the umbilicus of the urachus is hanging. And if you mobilize the bladder too much, the bladder will fall down and the vascular pedicle will not be seen very well. If you mobilize the lateral space a little bit, just sufficient for a vascular pedicle, the whole bladder will still be held and the pedicle will be standing straight and you can easily take it down. As a surgeon, it is your job to show the assistant the pedicle very well. Don't scream at him or anything like that. He's not coming in with a stapler, ligation very well. It's your job to show him straight. He's coming straight, you do it. So don't mobilize the lateral space too much. If you do that, the bladder will fall down. That is an important message. So to achieve that, this is the medial umbilical ligament. You're going to see a vast difference here. Keep your dissection just below that. Don't go above that. If you do that, the bladder will drop down. So you'll see it here. So you see the vast difference here. So you keep your incision at the vas just below that, and you don't want to go above. So when you do this, the third arm is held by the, or the assistant holding the medial umbilical ligament, give a good counter traction. So you don't, and then take down the vas, then come down with the peritoneum as slow as possible. But after that, the moves are going to be very blunt, small moves. Again, I'm showing you the natural videos, it's not for us to prove that we are doing a good surgery. It's the idea is to show you how a normal way it's done. So they're doing it very slowly and nicely. And now you watch it, the third arm is giving more traction, assistant giving more traction. There is a loose area tissue. I'm going to stop here 1 second. Here is the iliac vessels. This is the bladder, this is the pedicle. As you go in there, you take your camera inside. As you take the camera inside, it's going to hold the tissues nicely as well. You don't want to move anything to the lateral side. You don't want to push on the lateral side because your iliac vessels, you can, do damage to the iliac vessels. You don't want to do that. Rather, use the right hand, go in, push the bladder medially so that it's very safe and you're going towards the endopelvic fascia. And mentally, you'll think that the endopelvic fascia will be upwards that way. But in fact, because the way the patient is upside down, you need to go down that way, not up that way. Find the endopelvic fascia. It is going to be very simple, blunt moves. So the cameras went in. You just cut the tissue here, and then just simple moves, and you go in there and spread inside, but more towards the bladder side. See that I'm going down, I'm not going upwards to find the endopelvic fascia. You can open up whatever you want to feel, but the endopelvic fascia is going to be here, not upwards. So intuitively, sometimes you think that it'll be upwards, it's not. So if you notice it as the camera comes in, it acts like a retractor as well. And you're almost there, and whoever is doing it, we are doing it slowly, and you're able to see the endopelvic fascia over there. And if you notice in a couple of minutes, the entire lateral space has been created by small blunt moves. Again, recap. Make the incision below vas difference. Don't over mobilize the bladder. Bladder will fall down. The pedicle cannot be seen. And second point is that give a counter traction with the third arm or assistant in the medial umbilical ligament. Third is that take the camera inside the space and give traction and always mobilize the bladder towards medial rather than the other way around. So now you can see that the whole bladder is mobilized, even mobilizing slightly above made the bladder come down. This pedicle is seen, the posterior plane is done, entire pedicle from prostate to here is seen easily. So that is the idea behind doing the lateral space. And vascular pedicle, probably I'll stop with this and then we can go for the discussion. Vascular pedicles, depending on where you live, what you have, you can use anything you want. You can use robotic stapler, you can use an articulating stapler, you can use a standard stapler, you can use ligature, Hemlock clips, harmonic scalp, anything you want. But as I mentioned earlier, it is your job to show the pedicle very well to the assistant and don't blame the assistant. So I'm using a robotic staplers again because I don't want to use the assistant. Now this is a robotic stapler. I'm applying it myself, inserting it there, clamping it. You will see all the numbers here. It's clamping. Now it's firing. On 1, 2, 3, it's going to fire. And we are done with the superior vesical pedicle. And again, this is unedited video. You can see that it is reasonably quick. And now it's unclamping. And pedicle is done, particularly if you have a 60, you can have superior and inferior. So the entire bladder pedicle is done in probably 1 minute or so. And this is the prostate pedicle. Now you can choose to do either nerve sparing or you don't want to do a nerve sparing. It's up to you. So this is the robotic stapler. Now, when you're coming with the assistant using the stapler, again, he's coming from the left side, he's doing the right side. He is going to bring in the stapler any direction you want. But once the stapler is there, you use your graspers to bring the vascular pedicle into the stapler. So that way you need to work together so that they can help each other rather than struggling. So now he's going in there. This is a 60 stapler and he's taken the whole pedicle. And once it's done, he's going to close it. Once it's closed, you're still safe, reversible. You check everything, make sure that he's taken correctly. And then he fires. And you're done as well. That's the second way of doing it. And usually, like most times, it's hemostasis is very good, but be prepared if there is any bleeding, deal with it as well. And you can use the non-articulating stapler as well. This is a non-articulating stapler. I'm just trying to show all the different ways of doing it. And that is done also. Or You can use hem-lock clips. If you don't have it, you can do little by little. You can use hem-lock clips and you can divide. It takes time, so you can do it also. This, when it's done with hem-lock clips, is done very well also. Or you can use harmonic scalpel as well. So the idea behind this whole thing is that do the vascular pedicle in a very controlled fashion and don't mobilize the bladder too much. Bladder mobilization, you all do. On the prostate dissection, I do. Again, like a prostate dissection, don't open the endopelvic fascia too much. I think because it's almost 7:45, I'm going to stop soon. Well, let me see what apical dissection, all these things, this one I'll show you. I want to say this correctly. So when you're doing the apical dissection, if you're doing a neobladder, you want to protect the sphincter and also the prostatic, the hood very well. This is a little bit over dissected. Normally, don't dissect this too much. And you want to do a clean dissection. And in the early part, better for you to suture first and then divide. So, but at the same time, you want to maintain the preprostatic ligaments if possible, particularly in the prostate. So the idea is to take the stitch behind the preprostatic ligament, sew the dorsovenous complex, and protect the preprostatic ligament. So the way it's done is this way: you first take the stitch behind the preprostatic ligament, and then take the stitch under the dorsovenous complex, and then come back again under the preprostatic ligament, and then tie it so that the dorsovenous complex is sutured under the preprostatic ligament. And this particular patient, they've over dissected the endopelvic fascia. You don't really need to do it. Probably it's an old video. Nowadays, we maintain the hood completely and we use barbed sutures. So this must be probably 10 years old. But idea is this: go behind the preprostatic ligament and then suture the dorsovenous complex, both for the prostate and the neobladder as well. And I think because the time, I'm just going to stop at the moment. And I want to show this last one old video. Pelvic lymph node dissection has changed over a period of time. Now I use many things. I use free circulating DNA. I use PET CT scan to decide, and also the stage of the disease, how much lymph node dissection you want. But in the past, they asked us to do the lymph node dissection, completely. The lymph node dissection of the robot is a function of the surgeon. Whatever the surgeon wants, the robot will do for you. You can start from the aorta, you can start from the iliac vessels, or you can just do the operator nodes as well. It's all up to you. With the robot, this video just shows that everything can be done robotically, and you can see that there's the right common iliac vessels, common iliac artery can be dissected, and then if you notice it, the entire thing has been dissected completely. And again, this is the bifurcation of the aorta. You can start from there and you can go down as well. Again, the idea behind this video is not to show the lymph node dissection. All that I'm showing is that everything is possible, and you need to have patience, and you need to do this. And here is the left external iliac vessels, and then you'll be able to see the common iliac vessels. You can stop there, or you can go up to the aorta as well. So every single thing is possible. This is the pre-sacral nodes as well as possible. But to be honest, right now, we don't do this much. I only go by what the findings show and then tailor it to the need of the patient rather than doing full lymph node dissection everybody. I think I'll stop with this because I've exceeded my time quite a bit. Thank you very much for your attention, and I'll be happy to discuss any questions.
Thank you, sir. Thank you very much, sir, for that awesome, awe-inspiring presentation, going to the nuances of the technique and looking it very much possible to be done by all the young urologists too. So I have a few questions to discuss, sir.
Sure.
So
Sir, before
while mobilizing the...
Soundarya,
Yes, sir.
before you
Yes, sir.
take over, sir, being a laparoscopy and robotic surgeon for last 20 years, I must tell you, your focus, this actually the pure urology forum is mainly for technical aspect. Your talk was absolutely crisp. I missed the talk in Hyderabad. Since then, I was thinking how to listen. A lot of audience appreciating your simplicity in explaining the things. We really appreciate and thank you very much. Let Soundarya interact, because whatever the questions I interacted already, let her interact. In fact, she requested that, sir, Manoharan sir, I know very well. Let me also ask questions. Please give the junior a chance to interact with you, sir, please.
Thank you very much, sir. I really appreciate your kind words, and thank you very much for everything. I'm
Really
sorry if I rushed because I want to cover everything in a short time.
Yeah,
Thank
yeah,
you very much.
I highly appreciate it. This is a big topic, two big topics, sir. Thank you. Soundarya, please.
So while mobilizing the bowel segment, if there is a short mesentery, we are going to resect around 3 centimeters of the bowel and 3 centimeters of the mesentery, you were saying, because it is a 60 millimeter stapler, 6 centimeter stapler line. So in that case, if that 3 centimeters of mesentery which we have mobilized is not sufficient to reach the urethra, so would you be, what are the steps you will proceed with? How far you will go, and what is the arch of the blood vasculature which you will see, and what is your limit? How will you assess actually in case if it is not reaching, and or would you change the position, D-dock, and decrease the Trendelenburg angle? So what are the steps and how to go about?
So, just for the benefit of the audience, the question you're asking is that one, when you resect the bowel, the mesentery doesn't reach. What are the things to do? That's your question essentially, I think. But that's why remember, like we are actually going to take the apex of the neobladder first. It's going to already it's anchored to the the urethra already, so the mesentery is already reached. So by doing that way, there's no question about the mesentery resection. Already we are already the neobladder is already anchored. You just need to resect the 3 centimeters of the mesentery. But however, when you're taking the neobladder down to the urethra, the mesentery may not reach, correct? So that is you'll know beforehand, hey, the neobladder is not reaching, what can I do? So now what you do is that, like, you remember this, there's a staged stitch at the apex. With the third arm, take it down all the way to the pelvis as much as possible. That's the first thing. And then you see the mesentery being very tight. Then you start making incisions in the peritoneum or the mesentery, like a zigzag thing to release the thing so that you can move little by little, little by little. But with the robot, you only want to go, because with the stapler, only one arch you can go. But if you go more deeper, and that too without visualizing the vessels, because with the robot, you can't really visualize it very well. And the robotic with the staplers will go blindly quite a bit distances. You risk devascularizing the neobladder, losing the entire neobladder as well by doing that. So that is why it is important for us to take the neobladder down to the urethra first before you resect anything. The best things to do are following steps. Step one is that, like, keep changing the bowel segment until you choose that segment which will reach the down, the urethra. Secondly, lift the apex with the third arm on the stay suture, give a good tension, then you can see the mesentery very well. I'll make multiple Z or no, Z kind of a incision in the peritoneum that'll release. Thirdly, when you're lifting it up, if you're able to see, hey, this is holding, if I cut the vessel there, will it be devascularized or not? You can look at it. And if you think that you can take a risk, you can make a small Z incision on the resection thing, which will take it down. But remember, patient's welfare and quality of life is more important than doing the neobladder. If you have a single doubt in your mind that neobladder is not reaching or going to be devascularized, either try an open thing to check again or do a conduit. Just because you're asked to do a neobladder, don't risk the patient.
Sir, and do you or have you done the spherical kind of neobladder? Do you bring a certain part of the bowel segment which was isolated? Do you fold it up inwards, and do you aim to make a sphere, or you just make a invert the U and make a pouch like that? Do you aim for a
Sure.
sphere?
Sure. So, can I give a philosophical answer for this question again? Particularly young urologists, when we were 1980s, I finished med school in 1988. At the time, we used to look at the textbook and our seniors, what they said. We thought that's gospel, and we followed everything they said. For example, about the sphere, increasing the volume, twisting the bowel, etc. You need to think carefully yourself whether what is being said is true or just making it up. So the reason for that, why I'm saying, is that you do any neobladder you want. 6 months later, do a cystogram. All of them will be a sphere. Okay, so like a twisting this, for example, the student will twist the thing from one to another. They will do a T-shaped neobladder. They fold it inside. All those things will finally turn up as a sphere. So the simplest thing is best for you. I've tried every single thing, and all of them end up as the same one only. So we want to make it simple. The most simplest form of the neobladder right now will be having a U-shaped neobladder and then a chimney. I explained to you why I wanted a chimney. I'll explain one more time. Let's assume you're doing a Hartmann's pouch where you have a W, right? You have a limb on the right side, limb on the left side. But remember, if you have the limb on the left side, again, the ureter is going to be above the sigmoid. That's number one. Number two is that you can take it underneath. If you need to redo the neobladder conduit, you have to take down everything. You have to take a new segment and you have to do the conduit. It's so difficult, it's almost becomes impossible sometimes. Whereas if you use a two-disc one or use a U-pouch with a chimney, you just divide at the bladder neck, meaning that where the chimney is joining the neobladder, and flip it to the skin surface, you're done with it. So when you do a U-pouch, it gives you the same sphere. If you do rotate the thing and invert it and flip it, you get the same sphere. So for me, it did not make a difference. And I to be honest, over the last 30 years, I've done all the 3 or 4 on my own version as well. All of them end up the same. Hope I didn't
So
say
do
something
you
wrong.
Absolutely no, sir. Sir, the stent, how do you secure the stent? Do you actually secure the stents, ureteral stents? And what are your tips to remove the stent? And how many days later, how many days post-operatively do you prefer stent removal and the catheter removal?
So basically, like there are many different ways of doing it. I do it one way, but it's not necessarily that is the same way. I use a single J nephroureteral stents, so it goes to the neobladder, goes all the way up to the kidney, but I bring it out through the anterior suture line, and I bring it out to the skin on the right-hand side on the skin, and I close it with the two V-lock sutures. And 2 weeks after the surgery, and everything's good, I just remove the stent from the skin. That's what I do, and then leave the catheter for 1 week after the stent removal. Again, I repeat, I remove the stent 2 weeks from this post-op day 1, and then leave this catheter for another week for the opening to close, where the stent was coming out. And then 1 week later, I'll remove the catheter. There are surgeons who leave a long stent inside the neobladder. And if that is the case, you need to remove this Foley catheter usually 3 weeks or 4 weeks. Usually I do it 3 weeks, remove it. Then I bring the patient back to the clinic or OR and do a cystoscopy and remove the stent. There are a couple of downsides to it. If you're going to leave the stent inside the neobladder, it protects the anastomosis, but it does not protect the neobladder. What happens here is that if the catheter gets blocked, the stent is inside, all the urine is in the neobladder, and mucus clogs the catheter. You can get a rupture of the neobladder, or urinary leak can happen. There is a third way some people do it. They bring the stent through the urethra, then secure it to the catheter, and when they remove the catheter, stent, everything comes out together. So the 3 ways of doing it, but I bring it out through the skin because it's easier and it's well controlled.
Do you use a 22 3-way, or what is the size of the catheter which you prefer, sir, per urethral? And have you ever kept an SPC?
Sure. So again, in the late 80s, we used to use a suprapubic catheter every single patient. The reason for that at the time is that there are fear about catheter getting blocked, and then we have to irrigate the mucus. All those fears were there. But the problem with the suprapubic catheter is twofold. It leaves a big opening in the neobladder. And when you remove, when you're dealing with it, when you remove the suprapubic catheter, you have to put the Foley catheter again and leave it for another week or 10 days. Hope and pray that the opening closes on its own. But sometimes when you put a big suprapubic catheter, it's a longer one. But the worst thing that happens is that when you want to go back to the abdomen again, for some other reason, whatever reason may be, this neobladder will be stuck like a concrete to the suprapubic tract, and you will. Whenever you open the abdomen, you'll rip the neobladder into two because you cannot separate it. So that is the reason why it is preferable not to do a suprapubic catheter. Instead of that, you just leave a 22 French Foley catheter. I leave two-way catheter because through that you can irrigate. The reason I bring the stent out is that it acts like a suprapubic catheter. At the same time, it protects the anastomosis as well. And most of the urine, 90% of the urine will come out through the stent in the first week. So during that time, the neobladder heals. That's the biggest advantage.
Do you give anticholinergics in the post-operative period, sir? And for how long, if at all? And have you faced the problem of the patients having nocturnal incontinence? And when do they settle post-operatively?
So I'll go back to the nocturnal incontinence. So basically, how many minutes I have so that I can tailor my answer? It's a long
Problem,
answer.
so we can discuss another 10-15 minutes.
10 minutes. Okay. So can I speak about nocturnal incontinence, if you don't mind? Okay. So the many people notice that the neobladder patients, whether you do a beautiful job, a patient is great, they still have nocturnal incontinence. It goes back to the natural anatomy and physiology as well. Normally, when you go to sleep, the muscle tone, particularly all the muscles, skeletal muscles, including sphincter, the tone is very low. And the bladder is empty as well, and you're sleeping. But as the bladder fills up, as it stretches, the stretch fibers send signals back to the brain, efferent fibers, saying that the bladder is expanding. As the bladder is expanding, when the signal goes to the brain sends back signal back to the sphincter, and the sphincter gets tighter. More the bladder expands, the sphincter tone increases in a similar fashion. But when you have a neobladder, you remove the natural bladder, you put a neobladder, the bowel does not send efferent signals back to the brain. So the sphincter thinks that the bladder is empty and the tone is very low, whereas the bowel is expanding. And when the bowel expands to the full amount, even though you detuberose it, there is a mass contraction of the neobladder happens, and the sphincter tone is low, and people leak urine at night time. So this is the mechanism why nocturnal incontinence happens. So you have to think about how I can avoid it. So it's the same as BPH patients. I tell them to drink fluids as much as they can up to the midday. On midday to 5 o'clock or 6 o'clock, drink half the fluids. After 6 p.m., do not take fluids unless you're thirsty or if you're going out for a party or something like that. So keep the fluid like, and before you go to bed, I ask them to go urinate twice. That's double voiding to empty the neobladder completely. So when they go to bed, they make little urine and the bladder is empty. The third is that I'll tell them to keep an alarm and they will wake up in 4 hours and try to urinate. So you need to do all these three things to make the patient continent at nighttime. So the nighttime incontinence has nothing to do with you or the sphincter or the patient. It's more with the physiology of it because the bowel does not send different signals back to the brain. That's about the nocturnal incontinence. Sorry, the first question you asked, I forgot.
The anticholinergics postoperatively.
Sure, I don't use it actually, to be honest. If really did not really help too much, I've tried it. I don't use it.
So do some patients become hypocontinent, sir? And do they face the problem of the CIC not able to empty the neobladder completely?
Sure. So basically, there are men and women, right? In men, almost more than 90% of the people are able to urinate very well, if not more, without the need for CIC, particularly the patient is fit. You need to choose the patient wisely. If you choose a patient who's 85 years old and has got obese and is a big smoker and does not exercise, they do not generate enough abdominal pressure to empty the neobladder. Neobladder has to empty with generating the abdominal pressure. If the waistline is so big, if the BMI is more than 40, but if they're not able to generate enough pressure, they are not going to void, then they have to do CIC. But if you choose the patient wisely with a reasonable thing, even you can do an obese, not morbidly obese, I'm talking about. If you're able to do that, then most of them, men will be able to void very well. In women, again, in the beginning, they will void very well. But as the years go by, or 1 or 2 years go by, because most of the women are postmenopausal, and they don't have the ligaments strong and the muscles are strong. So the bladder flops back. I put a omentum behind, a omentum in front. I use the round ligament to suspend the neobladder. You do everything possible. But as the age catches up, the bladder falls backwards. You do a cystogram, you see the angle between the urethra and the neobladder is very high. That leads to hypercontinence, and they need to do a self-catheterization. There is a big difference between a woman and a man when they reach 75. When they're 75, whatever man it is, self-catheterization is very easy because you hold the penis and you can hold it, you can catheterize. It's very, very easy. There is no prostate. Whereas women, they might, like a man, they can have a hip replacement or osteoarthritis. Their hands are shaking. They will not be able to identify the urethra very easily. If they identify it, it's easy to catheterize. So in women, it becomes more and more difficult. And sometimes people who might done the neobladder when they are 58 years old, when they're 80 years old, like I have patients who might done the neobladder 20 years ago, 24 years ago, they want the neobladder to be converted because they're not able to empty the bladder as well. So these are the small differences between. So the catheterization rate in a male is about less than 10%. In women, after 2 years to 5 years, is 50%.
Last couple of questions, sir. In patients who have already had neoadjuvant chemotherapy, do you face any intraoperative difficulties while doing cystectomy?
Absolutely not. Like basically two things happens. So either if you monitor the patient clearly, they are going to respond or they're going to stay the same. So there is not going to be any big difference. And actually, if you don't tell me that the patient received neoadjuvant chemo, I will not know. However, there are patients who the 3 or 4 month period of neoadjuvant, the disease advances from T2, it might have become a T3B. But you think that the case is difficult because they received neoadjuvant. It is more due to the disease progression rather than the disease itself. So there's a big difference in prostate. Sometimes when you give a prolonged ADT, you'll see some fibrotic changes. In the cystectomy, I've not seen that. It's more of a related to the disease than the chemotherapy.
In patients having concomitant upper tract disease, so would you complete a nephroureterectomy and still go for a neobladder? Or
Yeah, so there's
you do
no
not prefer, you prefer a condu?
No, it's a patient choice again. If the other kidney is well, and you don't expect any problems there, and the patient is young and motivated, there is no true contraindication to do the neobladder. But if you leave the choice to me, the patient has got already field changes with the bladder having cancer, upper tract having cancer. He's got a high chance of having cancer on the other side sooner or later. I'd rather prefer doing a cutaneous ureterostomy so that I can monitor it very easily. That's my choice. The patient will not choose it. And if the patient wants a neobladder, there is no anatomical or a disease-related contraindications, as long as the kidney function is good.
Okay, sir. Thank you so much, sir. And thank you for patiently answering all our questions and going to the finest points and making things clear. And thank you so much for your time, sir. And sorry for
My
waking you
pleasure.
up early this morning.
No.
And
Thank you very
so
much
much,
for all
sir.
the questions.
Thank you.
I'm
You've been
really
very
grateful.
kind enough. Thank you
again.
so
All the
much.
best. Thanks a lot. Thank you.
Thank
I
you,
can
sir.
answer.
Thank you.
Okay, I can log out. Right.
We are
Thanks. Thank you.
concluding the meeting here, sir. Thank you, sir.
Thank you.
Thank you.
Thanks a lot.